If you're just joining us, we're going to get started in just 1 minute. Okay, good afternoon, and thank you for joining. On behalf of Plexus Communications, we are pleased to partner today with the MPN Education Foundation, who will host this session with Dr. John Mascarenhas. This activity is supported through educational grants from CTI Biopharma Corporation, a Sobi company, Insight, and Karyopharm Therapeutics. At the conclusion of the webinar, we have a very brief survey that I'm going to be putting a link to that in the chat section, and then we're going to send you a link to that. If you'll just take a minute to complete that, it's all multiple choice, and there's just a handful of questions. It will be greatly appreciated. Your responses to those questions will help us to develop future programs on this topic. The MPN Foundation was founded in 2004 by MPN patients seeking to provide the resources for patients to educate themselves with the latest science and research on MPNs. The foundation has built close ties with top hematologists in the field, runs a premier patient conference with the Mayo Clinic in Arizona, and facilitates daily discussions via the MPN Net listserv, the oldest patient community dedicated to MPNs. Mark Rovner is a patient and a longtime member of MPN Net and will host this discussion. Thank you and welcome.
Thank you very much, Kim. As Kim said, my name is Mark Rovner. I'm a PV patient. I've had PV for 12 years, and I'm on a combination of ruxolitinib and interferon, and it's been great for me. And it's also a real pleasure for me to introduce Dr. John Mascarenhas, who is one of those top hematologists in the field. Dr. Mascarenhas is the professor of medicine at the Icahn School of Medicine at Mount Sinai. He's also director of excellence for blood cancers and myeloid disorders and a member of the Tisch Cancer Institute. He directs the adult leukemia program and leads clinical investigation within myeloproliferative disorders. As a clinical investigator in malignant hematology, he focuses on translational research involving MPNs and evolution to acute myeloid leukemia. He also evaluates rational-based novel therapies for patients with MPNs and AML. And we all very much appreciated rational-based understanding of dealing with our illnesses. And so with that, let me turn it over to Dr. Mascarenhas.
All right, thanks, Mark, for the introduction. Thank you for everybody for inviting me to join you today on this topic. I'm going to share my screen. Sure I get it right.
And while he's doing that, I just add, Dr. Mascarenhas is going to present for 45 minutes, and then he'll be able to take questions at the end in the last 15 minutes.
Yep. So with no further ado, I will get started, and I truly appreciate the invitation and the kind introduction. And today we're really focusing on the MPNs. We're really focusing on myelofibrosis, and one of the major issues that can plague patients with myelofibrosis, which is anemia, and the management of anemia. Here are my disclosures, both for research funding on top and then consulting fees on the bottom. As mentioned, this activity is supported by CTI Biopharma, a Sobi company, Insight and Karyopharm, and this is a focused discussion today on myelofibrosis and anemia. But to start it off, I just want to give the audience, and I recognize I'm talking to a patient audience today, but you'll notice that I am using slides that are quite medical. Not to overwhelm, and I'm hoping to not overwhelm today's listeners, but to but to speak to you very clearly and hopefully translate it into a patient-friendly presentation. But I want to first start off by putting myelofibrosis into perspective. Myelofibrosis is a chronic disease. It is a disease that one acquires in their lifetime, so patients aren't born with the disease, but they are likely born with a predilection or a risk of acquiring mutations in stem and progenitor cells in the bone marrow that then over time, and it takes time, develop a overt clinical phenotype that's myelofibrosis. And you can see what I've done here is try to outline three sort of major aspects of myelofibrosis as they affect patients. One is the cytokine-driven systemic symptoms that I have listed over here. These are the fevers, night sweats, weight loss, debility, fatigue, bone pain, itching that can really compromise quality of life and functionality. The other aspect is the aberrant, inappropriate trafficking of these myelofibrosis stem cells into the blood and then to other organs, namely the spleen and the liver. So you'll often hear the word organomegaly or extramedullary hematopoiesis, meaning all of a sudden these cells that should be residing in the bone marrow, doing normal bone marrow activity, are now in other organs outside of the bone marrow, causing enlargement of those organs. And that can be accompanied by discomfort in the abdomen, particularly in the left upper quadrant, difficulty eating, bloating after full meals, even simple, almost vain things like not being able to wear clothes normally because your abdomen is protuberant. And there can be a lot of complications that can arise from having enlarged organs from extramedullary hematopoiesis. And then the third important component of this tripod is the blood counts and the tendency over time, particularly for worsening hemoglobin, that's anemia, and worsening platelet count, that's thrombocytopenia. And sometimes the white count can go quite high, sometimes that can go low, called leukopenia. Every patient with myelofibrosis really presents very differently and has a very different clinical course over time. But they do share elements of these features, some more than others. So not every patient is uniform in their presentation and in their needs and goals of therapy. There is a risk over time in patients that can be quite anxiety provoking, that the disease, myelofibrosis, which is essentially a chronic form of leukemia, can develop into an acute leukemia. And of course, that is frightening and that is a worry. And that's one of the things that we look at very carefully. And particularly, you'll hear the word blasts, B-L-A-S-T-S. These are immature cells that can circulate in the blood, and that can be one indication and one parameter that we watch for to make sure that patients aren't transforming to a leukemia. We do worry that these patients with myelofibrosis can have a shortened lifespan. And if you take all comers with myelofibrosis, the median survival is somewhere between 5 and 6 years, but you can have significant variation in that. Patients can live I have patients who've had myelofibrosis for 30 years. So there can be a lot of heterogeneity. And I am going to point out something very important is that those survivals are improving. Our treatment approaches have impacted not just quality of life and anemia, which are absolutely important, but also survival and outcome. And we have a lot on the horizon that I genuinely and significantly think will improve the outcomes of all of our patients. We often are asked, what is the stage of myelofibrosis? And myelofibrosis is not like breast cancer or lung cancer, and it's not staged in that way. But we do use risk stratification tools. So tools, and here's one example, the IPS, tools that can be used, and you can find all of these online, actually. They're very easy to locate. But tools that can be used that can take factors that we know have prognostic significance, advanced age, symptoms, anemia, high white count, the presence of these blasts in the blood, and we can create calculators. We can create risk groups, and we can put patients into these risk groups simply to give us a sense of where do you fall in the spectrum of disease, and that sometimes helps inform a risk-adapted treatment approach. Meaning, patients with higher risk disease are often those patients that would be considered, if applicable, for a bone marrow transplant, the only curative option that we have currently for myelofibrosis. We know mutations matter, and mutations are very frequent in myelofibrosis. So you'll see on the left-hand side, the most prominent mutation is a JAK2 mutation, but about 25 to 30% of patients can have a CALR mutation. And then a small sliver of patients can have a mutation in a gene called MPL, MPL. And then there's always a 10% population in every study that lacks any of these three driver mutations. We call them triple negative disease, and that has nothing to do with breast cancer. It's triple negative in the setting of myelofibrosis. On the right, you'll see that the driver mutations aren't always alone. Sometimes patients will have other mutations, what we call subclonal mutations, and those mutations can sometimes be used to better understand the complexity of the disease and even for prognostic significance. Here I'm showing everyone the complexity of myelofibrosis. It is not a one gene causes the disease kind of a phenomena. We see different driver mutations, as I mentioned, JAK2, CALR, MPL, but we can also see all these other genes. Each one of these labels down below is a gene. It's a gene that can be mutated. In fact, many of you probably are aware that your doctors may have obtained next generation sequencing. We can look at all these genes and see, are they mutated in your blood cells or in your bone marrow cells? And does that give us a sense of your disease process? And maybe even for some clinical trials, targeting of those mutations. Here's an example for the audience where I alluded to integrating mutations into risk stratification. So this is called the MIPS 70 plus risk score. You'll notice a lot of the same variables I mentioned, anemia, blasts, symptoms are used, but then increasingly we're using mutations like the absence of a calreticulin type of mutation, the presence of a high molecular risk mutation. And you can see the asterisk down below defines some of those high molecular risk mutations like ASXL1, EZH2, SRSF2, IDH1 and 2. And I meet patients and they know what their mutations are, and other patients don't, and that's okay. But for the physicians treating you, it is helpful for us to know, do those mutations exist in you? Because they might influence your prognosis, they might make treatment decisions more obvious, and not always. So sometimes we have this information and it doesn't significantly impact or influence our treatment decisions. But you can see that mutations, the number of mutations, and the karyotype, what do the chromosomes look like in the blood cells, can all be used in these risk scoring systems to help better understand the complexity and prognosis of your disease. Now, I'm going to move to the treatment approaches to myelofibrosis, because I think for many patients, that's a very key aspect of understanding. And what I've shown you here is what I like to look at is goal-oriented treatment approaches. So the clinical issue is sort of the goal shown on the left: anemia, big spleen, systemic symptoms, all of these aspects of the disease that can be shown on the left. And on the right are the array of treatments that we use to address those goals of therapy. So for example, and today's topic, anemia, you can see the term ESA. ESA is for erythropoiesis stimulating agents. These are growth factors that can be injected into your skin, usually intervals of every week, 2 or 3 weeks. And they can sometimes be helpful in certain patients to boost up the hemoglobin. Danazol is a synthetic male androgen used for probably 30 to 40 years now, actually approved for endometriosis, a totally unrelated disease. But we realized many years ago that it can actually improve hemoglobin in some patients with myelofibrosis and related diseases. Corticosteroids, like prednisone, have historically been used to boost up the hemoglobin in some patients. And then IMiDs on the right, thalidomide or lenalidomide, are drugs you may have heard before. These are oral drugs that can also be used in some patients and have historically been used in clinical trials to boost up blood counts. Now, you'll notice that I also have listed here momelotinib and pacritinib. These are oral JAK inhibitors. Pacritinib approved in 2022, momelotinib approved last year in 2023. And these are drugs that are used typically to address the usual JAK inhibitor issues that you can see below, like spleen and symptoms, in terms of reducing the inflammation that's associated with the disease, reducing the spleen size so that patients can move more freely, eat better, and drying up a lot of the symptoms that can plague patients that can really affect their functionality and their quality of life, like those night sweats, the fatigue, the inactivity, the bone pain, etc. But momelotinib and pacritinib may stand out in the crowd of JAK inhibitors because they have also been tied in to improvements in anemia, which we'll discuss. So that's sort of the framework that I'm gonna start with today, and I'm desperately trying to speak to this audience at a level that I'm hoping people will appreciate and understand as non-physicians, but desperately not trying to talk down and show you slides and data that we would actually use to talk to other physicians. So in this slide, what I'm trying to help the participants today appreciate are the different JAK inhibitors and maybe some of the nuances, because many of you on today's call may be on a JAK inhibitor, have been on a JAK inhibitor, may be considering a JAK inhibitor, and there are 4 JAK inhibitors that are approved: ruxolitinib or Jakafi, fedratinib or Inrebic, pacritinib or Bonjo, or momelotinib or Ojara. And I always recognize when I say this to patients, these are mouthfuls of names, and they really don't make any sense. And what they're really trying to do is capture that each drug is distinct and doesn't get confused with other medications or other terms. But these are 4 JAK inhibitors that are approved, and they all share something in common. They're all JAK2 inhibitors, but there are nuances. There are differences. There are differences in some of the mechanisms, some of the other enzymes that they can inhibit. And there are differences in their labels, their FDA-approved indications that end up in the package insert in their labels, which influence the ability for insurance companies to approve these drugs for individual patients based on the clinical picture. Jakafi was the first one. It has a pretty broad label, but platelet count greater than 50,000 is an accepted threshold or bottom limit for the platelet count. Fedratinib, same thing. Patients with intermediate or high-risk disease, platelet count greater than 50,000. Pacritinib is specifically for patients with less than 50,000, irrespective of whether they had a JAK inhibitor previously. And it's endorsed by organizations like the NCCN guidelines. This is the National Comprehensive Cancer Network, for patients after they've seen a previous JAK inhibitor, irrespective of a platelet count. And then momelotinib on the right was approved in October, November of last year for patients with myelofibrosis and anemia, not qualifying it any further than that. So patients who have anemia and have been on a JAK inhibitor in particular, for some patients, this may be a very appropriate drug. You'll notice that there's, in red, in the targets, there's ACVR1 that's highlighted in both these drugs. And the reason why it's highlighted here for this talk of anemia is that both of these drugs inhibit this important pathway that modulates a protein called hepcidin, and we're going to hit on that today a little bit. Because what I'm also going to try to explain to the audience today is not just the drugs, but maybe the why we use these drugs, maybe to give it a little bit more sense or rationale, and perhaps a little bit more confidence in the patient population mechanistically why we do what we do. And to talk through today's discussion, I'm going to use some cases, these cases obviously aren't based on anyone watching this, nor necessarily any real patient, but are meant to really just highlight, the kinds of things that a physician who treats MF can see. So here's a 76-year-old gentleman who comes in with fatigue, real bad fatigue, can't really carry on the normal activities that his family would normally expect him to do. He's losing weight and not trying to lose weight, and it's not the kind of weight loss that people are happy with. It usually is like wasting of their temples, their arms and legs are skinnier. And it's a weight loss that's often more ill than flattering. And then abdominal fullness. The abdomen is really sort of grown and is much more protuberant. So the physician sees the patient and can quickly see by palpation the spleen is quite big. It's 12 centimeters below the rib, and the white counts, blood counts reflect a normal white count, 9.5 thousand, but 3% circulating blast. Now, in normal situations, you should see no circulating blast. So that tells us that there's something inappropriate going on. And hemoglobin of 10.5, and just so people understand, that's anemia. Hemoglobin below 12 or 12.5 is typically considered anemia. And then platelet count of 181,000. That's a low but normal platelet count. A bone marrow biopsy is obtained, and the three key features, patients always ask me, well, what do you look at in a bone marrow? Well, we look at cellularity. So there is a lot of cells, 90% cellularity in the bone marrow. That's more than expected. That's a myeloproliferative feature. And myelofibrosis is a myeloproliferative neoplasm. There are dysplastic megakaryocytes. If you've ever looked at a bone marrow biopsy, one thing that is very striking is very large conspicuous cells. Those are megakaryocytes. They give rise to platelets. Even a first-year medical student, if you start looking at bone marrows, you can spot them real quickly. These cells are very funny looking, atypical in myelofibrosis, and they usually sit in gangs or clusters, and they shouldn't be doing that. So that's a feature that we look for in our patients' bone marrows with myelofibrosis to make sure that that's what we're dealing with. And then fibrosis. Fibrosis is graded 0, 1, 2, or 3. In this patient's case, he has very dense fibrosis. It's dense fibrils, which is scar tissue, and it's crisscrossing, and it's really distorting the architecture of the bone marrow. And 5% blasts. So these are immature cells. So it's the borderline of what you would expect is normal amount of blasts in the bone marrow. The chromosomes that they look at are normal, so that's good. And on testing by sequencing of the genes from the blood cells, there's a JAK2 mutation, a very specific one, B617F. That's the most common JAK2 mutation that we see. And there's also another mutation, ASXL1. If you remember, I said some patients have a high molecular risk mutation. That's an example of a high molecular risk mutation. So the patient is given the diagnosis primary myelofibrosis of the cytopenic subtype, meaning low blood counts, as opposed to a patient who might present with a very high white count, like 30,000, and a platelet count of 500,000, and a hemoglobin that might be closer to a normal range. And this patient has a risk score that's in the intermediate to or high risk category, depending on the calculator used. So the question that we ask ourselves in conferences and in real care is, well, what's the best treatment for someone who comes in who's older, who's not feeling well, who has all these symptoms, has a big spleen, and has blood counts like this in the setting of primary myelofibrosis? Is it ruxolitinib, Jakafi, fedratinib, Inrebic, pacritinib, Vonjo, momelotinib, or do we have other, do we have the ability to choose one or the other drug? And again, my talk today is not to quiz the audience, but to put this in framework and give you a sense of how we come to these decisions and how we talk about it at meetings and to each other. So some of you who've been on Jakafi or maybe on Jakafi might wonder, well, where does the data come from for these studies? Well, this is the phase 3 comfort studies that led to the approval of Jakafi. And I don't expect you to memorize this or totally figure out what I'm showing you. But what I want you to understand was these were big trials, particularly at the time, that were done across the country and then across the world in Comfort 2, taking patients who had never seen a JAK inhibitor with all these criteria that made you eligible or ineligible, and they simply got Jakafi at 15 or 20 milligrams versus placebo, a sugar pill in the US, and outside the US, the physician could give them whatever therapy they thought was appropriate at the time. And the primary endpoint of the study, meaning what the FDA wanted to see, was, well, how much spleen volume can you reduce in these patients? Because Jakafi can reduce spleen very significantly. And we'll use that as an endpoint, a regulatory endpoint, to approve the drug in combination with improvement in symptoms. And what you can see is that Jakafi is very, very efficient in achieving spleen volume. In 42% of patients, they had at least a third of their spleen volume reduced versus basically no one with placebo. And on the right, you can see in orange with the bars going down that in each case, Jakafi improved the symptoms, whether it was abdominal discomfort, pain, early satiety, getting full very quickly, night sweats, itching, muscular bone pains, and just being inactive. Whereas in blue, in placebo, during that 6-month period, the patients all invariably got worse with their symptomatology. So the drug was very effective in reducing spleen, very effective in reducing symptoms. It does come with a price tag. There are some toxicities with Jakafi, but in the setting of hem-onc, I would say that it's a very well-tolerated drug, and we go by grade 3 or 4. That means a very significant toxicities where it really is affecting quality of life and functionality. You can see the frequency of these significant toxicities when compared to baseline placebo is the same. We don't really see a lot of toxicity, but what you do see is lowering of blood counts, and that's the message for the audience today: is that you will get anemia and thrombocytopenia, low hemoglobin, low platelet count with Jakafi. It's sort of expected. It's on target. It's not failure of the drug, it's part of the mechanism of the drug. It will induce some degree of anemia and thrombocytopenia. What about fedratinib and Rebic? Sometimes patients have seen this drug or the physicians have talked about it. This was it is another great drug, and it's another study looking at fedratinib and Rebic in patients who had not been treated with a JAK inhibitor. And the point of this slide is to show you, just like Jakafi, in Rebic was a very active drug. The 400 milligram in orange is the approved dose, very active in significantly reducing the spleen in a third of the patients. But in reality, most patients like Jakafi had some degree of reduction in spleen and benefit of the drug. Like Jakafi, in Rebic is also associated. You can see again this grade 3/4 thrombocytopenia and anemia can be seen with in Rebic as well. So these drugs can induce, by mechanism of action intended, can induce some degree of lowering of the blood counts. In Rebic's a little bit different profile. It can also have some GI toxicity associated with, more so than with ruxolitinib, but very easy to overcome with prophylaxis. It occurs in about half the patients, usually in the first 1 to 2 months. So let's go back to the patient. So this patient goes on ruxolitinib, actually, has very good improvement in symptoms. The spleen gets smaller, the activity of the patient increases. The patient's definitely benefiting from the drug. Comes back to see the physician. White count is 8,000, hemoglobin is 8.5, so it went from from 10s to 8.5, platelets 101,000. 5 months after starting Rux, the night sweats then unfortunately start to come back, and his spleen starts to get bigger, and he's starting to have more early satiety. And the question is, well, what do you do now if someone has been on Jakafi and is having some progression of their disease in terms of symptoms and spleen? Do you add drugs to the Jakafi? Do you switch them to another JAK inhibitor? Sometimes patients ask me, do we take out the spleen, or do we irradiate the spleen? Do we give radiation to the spleen? And there's a lot of different answers, but what I'm trying to point out here is that when we see patients not doing well, particularly on a first-line JAK inhibitor, we do worry that that's telling us that the patient is in a pool of patients where their outcome may not be good at all and may be very compromised. And that identifies what we call a Rux discontinuation population. And those kinds of patients who have to come off the drug often don't do as well, and their survival can be affected. And that becomes a level of concern. I think that's always one of those situations too, where you want to make sure, ideally, that you're plugged in with a group hematologist that specializes in this area, that has some sense of how to move from that point if someone's not doing well on their JAK inhibitor. But the good part is we have available drugs, even commercially, that can help patients even when they're not doing well on their first JAK inhibitor. And here's an example, the Jakarta 2. This was fedratinib or Rebic at 400 milligrams once daily in patients who had already been on Jakafi and either had intolerance or resistance to the drug. And what we saw in this study, and again, in these are called waterfall plots. In these diagrams, all of these columns going down that are color-coded by whether the patient was resistant or intolerant to Jakafi are patients on the study, in this phase 2 study, getting in Rebic, that had reductions in their spleen volume on the left and in their symptom scores. So that's a good thing. They're having improvement in those parameters. So what this tells me very quickly is that a third of the patients, even after seeing Jakafi, enjoyed spleen and symptom benefit in the second line within Rebic. So that's reassuring that we can use and sequence other JAK inhibitors in the community to help patients if they're not succeeding on their first JAK inhibitor like Jakafi. So let's go back to this gentleman, 76, fatigue, weight loss, abdominal fullness, spleen is big. The white counts now are 2.3. Hemoglobin is really quite low, 6.5. That's in transfusion zone. Platelets are 41,000. That's a low platelet count. So the patient really has a cytopenic profile, a low blood count, 6.5 and 41,000 to the extreme. This is an example of where we now start to think about, should we be using lower doses of Jakafi? Do we use fedratinib in Rebic? Do we use pacritinib Vonjo? Or do we use Jakafi and combine it with a growth factor like ESA? What do you do in those kinds of patients? So in this kind of a patient, we start to think about drugs that were evaluated for this situation, this scenario, which is a drug like pacritinib. So this is the PERSIST-2 data set. So this was a pivotal phase 3 study that led to the approval of Vonjo in patients with platelet count less than 100,000. So this population, in every study, there's eligibility criteria for inclusion and exclusion. This study was specifically taking patients with low platelets, less than 100,000. And you could have seen Jakafi previously or not. Half of the patients did. And there were 3 arms on this study. But the arm that was most important is the arm that's approved today, the 200 milligrams twice daily arm. And what we saw in this study, again, you'll see a very common outcome measure here that becomes very clear, which is we're always looking at spleen and we're always looking at symptoms, particularly as it relates to the JAK inhibitors. Well, despite the fact that the patients had very low blood counts and had, in many cases, seen a JAK inhibitor before, 22% of the patients at 200 milligrams twice daily hit this magic endpoint of 35% or more. More than that enjoyed benefit from the drug, but from a regulatory endpoint, a strict endpoint, 22% hit that versus 3% in the arm. That was a control arm, which was basically dealer's choice. The physician could give the patient whatever they thought would be helpful. And then 35% of patients had at least a 50% reduction in their symptom score versus 14%. So there was a clear superiority of pacritinib to best available therapy at the 200 milligram twice daily arm. In the patients with platelets less than 50,000, which at that point was the unmet need, Jakafi and Inrebic were approved, but we didn't really have drugs for patients with very low platelets. This was a very successful drug in a third of the patients or a quarter of the patients with symptoms in terms of improving their disease burden. So this was a study that opened up the gates for JAK inhibitor for patients with low platelets, less than 50,000. And you can see when comparing the toxicity, like in Inrebic, we see a little bit more GI toxicity. It's sometimes it's diarrhea, sometimes it's nausea. It's very easy to deal with in those patients who get it, which is about half the patients, and there's no predictable pattern. I can never predict with either of these drugs who's going to get it and who's not, but I always warn patients you might get it. And if you get it, we can give you an anti-nausea medication. We can give you an anti-diarrheal like Imodium. It's very easy to control, and it's very rarely a reason for discontinuation, but sometimes it is. We also see maybe a little bit more bleeding. We don't know why, irrespective of the platelet count with pacritinib. So there are some patients where I am a little bit more cautious with pacritinib if they are bleeders, if they've bled a lot from previously, or if they're on anticoagulants. Now, I kind of teased you guys in the beginning with the fact that these drugs are not all created equally. There are some mechanisms that might help us understand why some of these drugs can be associated with anemia response. So here I'm gonna dive down, and forgive me if you hate science and never liked your biology class, but this is what I think is very fascinating and helpful as physicians and investigators and researchers to understand what we're doing, what we're offering you in terms of drugs, that we make sure that it makes sense from a mechanistic or biologic standpoint. Well, we've learned over the years that ACVR1 is a receptor that's expressed on surfaces of cells, namely in hepatocytes, which are liver cells. And it's important for the generation of a molecule called hepcidin. And hepcidin is the master regulator of iron. So it controls iron. It controls the influx of iron, the outflux of iron. It controls where iron is deposited and stored. But most importantly, in patients with myelofibrosis, this hepcidin, because of inflammatory reasons, is very high. So when it's very high, it's not allowing iron to get to where it should be, which is to the red cells that are being developed in the bone marrow. And that's a problem. That's one of the mechanisms that leads to anemia. The fact that you have an anemia of chronic disease, you have poor utilization of iron because of this high hepcidin level. And both momelotinib and pacritinib block this pathway and reduce hepcidin, thereby allowing better access of iron to red cells so the hemoglobin can go up. And that's I hope as simple as that. That's what we expect from these drugs. So the investigators took momelotinib in the Momentum study. This was a big phase 3 study, and took patients who had been on a JAK inhibitor previously, who had symptoms and anemia, a hemoglobin less than 10, or maybe needed transfusions, and a platelet count of at least 25,000, and randomized them to the study drug, which was Ojara, versus a drug that we'd given historically, danazol. We give danazol for anemia. We expect maybe 20 to 30% anemia response rate. And what I've highlighted down below is that Ojara was superior to danazol in terms of improving symptoms and reducing spleen, and it was non-inferior in terms of improvement in hemoglobin. And in this case, non-inferior is a good thing, meaning it proved that it can improve the rate of patients who are transfusion independent after 6 months of therapy, and it was 30% versus 20% in danazol. So here's a JAK inhibitor, unlike in Rebic and unlike Jakafi that I showed you before, that's associated, we expect anemia, actually with less anemia and improvements in anemia in some patients. Well, it turns out that Ojara, it was not the only kid on the block that had this ability. Pacritinib or Vonjo also did as well. So they're both ACVR1 inhibitors, and pacritinib, when we went back and looked at the data more critically, was associated with a transfusion independence conversion rate of about 37% in the patients getting the approved dose. So that's a pretty significant improvement in hemoglobin, whereas, again, with Jakafi and Rebic, we do expect it to go down. And no matter how you looked at the patients, and that's the point of this kind of analysis, whether you controlled for whether they had seen Jakafi previously, how low their platelet count was, how much JAK2 mutation they had, pacritinib was superior in these red bars in terms of the rate of conversion of someone who needed transfusions to being independent of transfusions. Now, some people on this call may have been introduced either from standard of care or from research purposes to a drug called luspatercept or Reblozyl. This is an injection, and it's kind of like an ACVR1, well, it is an ACVR1 inhibitor, but it's kind of like what Ojara and Vonjo do for improving anemia, except as a subcutaneous injection that's given every 3 weeks. That's very well tolerated. And what this does is it affects signaling pathways that can affect the red cell development, the maturation of red cells. So this was taken into a study, and this is a very complex study that even when we show it at medical meetings really kind of confuses physicians. But what I want the audience to understand is that if you look at cohort 3B, these are patients who are on Jakafi, receiving stable dose of Rux, that's Jakafi, and are needing transfusions, red blood cell transfusions, that's cohort 3B. And then if you go down here, if they get this drug, luspatercept or Reblozyl, this injection, that a third of them became transfusion independent, and half of them had a 50% reduction in their transfusion burden. That's pretty significant. We were seeing a really nice improvement in anemia with this drug as well, when added on to Jakafi. So what I'm painting is a picture where we have various tools at our hands. Some of them are old, like danazol or imids, steroids you can use for a short period of time. Some of them are new, and we're repurposing them, like the JAK inhibitors, like Ojara or Vonjo. And some of them are still on the horizon. They're approved for related diseases. I suspect by next year we'll have data out from the phase 3 study for luspatercept or Reblozyl that will make it an approved drug for myelofibrosis, but it gives us options for anemia. Now, there are a lot of stuff going on in myelofibrosis for the next generation of drugs that will hopefully improve our patients' outcomes, because we do see the outcomes improving with each 5 to 10 year period as we get better at treating these diseases, as our understanding of the disease gets better. I show you this slide again just to highlight the fact that these are very complex diseases. It really takes a collaboration of a lot of people, both with scientific understanding, clinical understanding, and translational understanding, to really take this complex disease biology and translate it to drugs that are rational, that are mechanistic, that make sense, that we're not just throwing a dart and hoping it works, but actually are informed from the science, and then have a better chance of helping our patients. And this to me is more of a slide as a pep talk to show you that we're really working hard at this. That if you look at all these drugs that we have here, all with funny names, bomedemstat, pelabresib, and imetelstat, TP3654, navtemadlin, selinexor, these are all very active drugs that have early clinical activity, have shown early clinical activity, that are now moving on into later stages of trials, so phase 2 and phase 3. Some of them have resulted, and today I'm not going to go through all of that data, but I do want to impress upon the audience that there's still a lot of clinical research. I still think that patients who participate in clinical trials just generally do better than patients who don't, because we're trying to build upon the standard of care. And a lot of that standard of care is now moving to combinations of drugs. can we combine drugs that have rationale, that complement JAK inhibitors like Jakafi, get deeper responses and more meaningful responses, and maybe even anemia responses. And just to that point, I'm just going to show you a couple of slides here just to impress you with some of what we're seeing in the form of Manifest-2. This is a drug called pelabresib.
Yeah, I was just going to say, Dr. Mascarenhas, after these couple slides, we'd like to pause for questions.
Sure.
And I have two quick questions for you when you do pause.
Sure, absolutely. So this is a drug that you may have seen, maybe even some of you have been on. That's an oral drug that's given 2 weeks on and 1 week off. That had very exciting and very encouraging phase 2 data. So it was taken to phase 3. Phase 3 is always a comparison. It's taking standard of care, so it's Jakafi plus placebo pill versus what you think might be better, and it's Jakafi plus this drug pelabresib. And here what we're seeing, as outlined here, again, these are the waterfall plots that we like to look at in our field. In blue is how much reduction in spleen you get with Jakafi alone. In red is the difference of how much more reduction you get when you add pelabresib. And you can see, if you look at the percentages, it's almost twice as much reduction in spleen volume that you get when you add this drug. And you get reduction in symptom burden, although I will point out for those statisticians in the audience, this wasn't statistically significant, but you do get reduction in symptom burden beyond what Jakafi does to some extent. And this is the slide for this talk, anemia, that I wanted to make sure we hit, which is, one of the things we're looking at when we combine drugs is, can we improve upon the fact that Jakafi is not necessarily an anemia improving drug? And here what I'm showing you in red is when you add pelabresib, you get less anemia. So this is the hemoglobin levels in the patients who were treated. You get less anemia because the red is sitting on top. And you do get the sense that there are patients who are requiring less transfusions and having better improvements in their hemoglobin level. So maybe Mark, I'll pause here. I'm happy to stop and take any questions.
Okay, that's great. I have first we start with a two-part question. One is, what about Aranes for anemia? And then related to anemia, when should somebody be concerned about low hemoglobin and anemia? Is there a number that triggers action, or is it a matter of patient reporting impairment?
Okay, so let me start with the second part. So this is an important question that gets asked a lot, is like, what hemoglobin level is too low or too dangerous? And the answer is, it depends on the patient. But in general, we take hemoglobins below 7 as sort of the threshold where we start to transfuse patients, give them red blood cells. In some patients, that level could be 8 or even 9, where you might start getting transfusions if you're symptomatic at that level. It also depends on how quickly you went down to that level and whether you have comorbidities like heart disease that your cardiologist might say, I want you at a hemoglobin closer to 10. So some of it really depends on the patient. As a general rule, we say less than 7, your transfusion requiring zone, but for some patients, they might need it even before. I would say if you start to see someone's hemoglobin going down, that's when you should start to try to react in terms of introducing some of these drugs that I discussed to try to change that trajectory, because with myelofibrosis, it's not just chronic, it is progressive, and that anemia will usually get worse. So we try to, the paradigm is usually to try to intervene and to give therapies to try to change that course so the hemoglobin doesn't continue to get worse and continues to go up. Most patients, if you improve their hemoglobin, will have some degree of improvement, not fully, but some degree of improvement in some of the symptomatology, like shortness of breath when they climb the stairs or just fatigue level. And then, Mark, I missed the first part of the question.
Oh, it was about Aranes for anemia. Darbepoetin.
Oh, Aranesp. Aranesp or darbepoetin is a type of growth factor that I mentioned. So that's a drug that can be given as a subcutaneous injection under the skin. And I would say any drug, so for anyone out there who's familiar with the term Aranesp, darbepoetin, erythropoietin, Procrit, Retacrit, these are all ESAs. They're all red cell stimulating agents that can be injected in the skin. And if your EPO level, which means your hormone, which is what those drugs are, they're just a laboratory form of a hormone that stimulates red blood cell production. If your endogenous EPO level is already high, those drugs probably won't work, actually. We know that. So it can be measured, and a physician can get a sense of whether that even makes sense for you to try. if your EPO level is on the lower side, about somewhere around 25 to 30% of patients will have pretty nice responses and improvements in those hemoglobins. So the majority of patients, unfortunately, don't really get great benefit. And even in the patients that do, the durability is often not that long. Sometimes I'm really pleased with the response and the durability of those agents, but often I'm frustrated that we need to do better than those drugs. But for some patients, those drugs can really be beneficial. And for most patients, they're not associated with a lot of toxicity. So
Right.
it's not a drug that will often make patients feel worse and can make patients feel better.
Is there any difference between the EPO stimulating agents?
There's no real there's a difference in the sense that drugs like Procrit and Retacrit are very fast-acting drugs, so they tend to be given more frequently, whereas drugs like Aranesp or Darbepoetin are more long-acting drugs, so they can be given less frequently. But as a group, all of these ESAs are basically the same. They're basically molecules that try to stimulate the bone marrow to make red blood cells, because the thought is that your own body is not producing enough of that hormone to make that happen.
Can I ask, so we just got a question. Somebody has PV and is on Jakafi, and their hemoglobin was 12.7. Is there something that could make this better?
So the question is someone who's receiving
Yeah.
Jakafi and hemoglobin is 12.7?
Yeah, I'm trying to understand the question.
Yeah, I'm not sure that I've
Yeah, they
um,
haven't. Yeah, there's somebody, I'm just, again, opening up to participants. Does someone else have another question? Well, in the meantime, let me ask you a question. Is anemia a symptom of disease acceleration, or is it just part of the cause?
That's a great question. And anemia, if you remember from one of my original slides, is definitely part of the disease process. About a third of patients will present with some degree of anemia at the time of diagnosis, but nearly 90% of patients will develop anemia over time because it's definitely part of the disease process and usually gets worse over time. So anemia is a disease feature. It can be worsened by some of the drugs we give, like Jakafi. It can be complicated by other things that are not myelofibrosis related. So, for example, patients who have kidney insufficiency or who have bleeding issues, like who have gastric ulcers that might bleed intermittently. Other things can also worsen and complicate the anemia in myelofibrosis. But we do know that anemia has prognostic significance. We know that when you start to see anemia and it's worsening in myelofibrosis, that definitely ups the ante and our risk concern level. And that's why there's a lot of emphasis on trying to treat anemia and to try to reverse the anemia. It's obviously to improve the hemoglobins, to get patients out of the transfusion suite, to make them feel better. But also, patients who have anemia responses tend to do better than patients who are continuously living in a state of anemia.
Okay. So I didn't ask this question, but someone in the group did. What do you think of the combination of interferon and Rux as a combo therapy, which is what I'm on?
Yeah, so it's a combo that's been tested more in Europe than in the US. And it's a combination that at first glance to me doesn't sound rational. So I talked a lot about rational therapies. And the reason why I say that is because interferon actually stimulates JAK-STAT signaling, and then you give Jakafi to inhibit that. And that never really made a lot of sense to me. But the reality is that there is clinical trial data that shows that you can combine the two. And in myelofibrosis, particularly patients early on in myelofibrosis, and you can improve the tolerability of interferon for some patients, and you can synergize the activity of the two drugs. And both Jakafi and interferon, particularly ropeg interferon, which is Besremi, have been shown in clinical trials in patients, particularly with PV, to not just improve the disease features like the hematocrit and the spleen and symptoms, but also to reduce the JAK2 mutation and to put patients into molecular responses. So there's a lot of interest in myelofibrosis, particularly early on in myelofibrosis, to see if the combination of those two drugs can also accomplish that in patients with myelofibrosis.
Thank you. Now, an anemia question. If you're anemic and all you're taking is prednisone, and you happen to be living in Canada where you don't have access to momelotinib, is there something else that they should consider?
Yeah, I mean, so prednisone, old drug, it's a great drug. It's still one of the best drugs I think we have for like everything. I mean, everyone feels better on prednisone. The problem is it's very hard to live, particularly on high doses of prednisone for extended periods of time because there can be complications of prednisone. So the drugs, and you know, as a physician who doesn't practice in Canada, I must admit, like I don't know exactly what's available in Canada per se. But if momelotinib is not available, which I thought it was, but if it is not available, you know, the options that would make sense if Bonjo is available would be Bonjo as the alternative JAK inhibitor in that setting, or drugs that we've used historically like danazol or IMiDs like thalidomide or lenalidomide. These are drugs that are all used and listed in compendiums for the treatment of anemia in myelofibrosis. So there are other options.
Okay. So I'm coming back to one of the questions. Oh, someone just changed questions. Somebody was on momelotinib and their hemoglobin went from 9 to 12, but they didn't experience any improvement in their fatigue. Is there a reason for this?
Yeah, that's a great question and a really interesting one. It kind of gets to something that I alluded to maybe vaguely, which is a lot of times when you have an improvement in the hemoglobin, patients can notice an improvement in their energy level, their fatigue level, shortness of breath. But if you notice, I did say, but not completely. So the tie-in between hemoglobin and symptomatology is not 100% for every patient, meaning a statement I've made to a lot of my own patients is that even if I were to transfuse you to a normal hemoglobin in someone who's anemic, most patients will come back and say, I still don't feel well. I still feel unwell. I still feel fatigued. I still feel sick. And that's because the disease is more complicated than the anemia. The anemia is a feature of it, and addressing it can help with certain symptoms to some extent. But often, if you're not on the right drugs, or even if you're on quote unquote the right drug, for you, that may not be sufficient to address all the aspects of the disease. And that requires, you know, the nuanced and more of the art of medicine with a physician who does a lot of this for, you know, for patients.
Thank you. You had talked just a moment ago about proliprazab. Sorry. The question is, do you know what the time frame is with the FDA for approval?
I wish I did.
Yeah.
That's the $1 million question. So that's the drug that was tested in Manifest-2 that has encouraging phase 3 data. You know, the pathway to approval is a very complicated and costly pathway with the FDA. So that is not clear. It is possible that by next year we may have updates on the status of that, you know, process of trying to get the drug approved. But I would say realistically, I don't see that drug being commercially available to folks in the community for the next year. It's going to probably take longer than that.
Okay. Well, for CALR multiple fibrosis people with anemia, is there any benefit to the new antibody treatments in trial?
Well, we don't know. I mean, they're still in trial. They're still early on. I am super excited by the immunotherapeutic approaches that we have for our CALR mutant patients. These are antibodies like Incyte's drug. These are what are called BiTEs, bispecific T-cell engagers like J&J Janssen's drug. And then vaccine therapies like we have at our institution and other places that try to rev up the immune system to create immune responses to the mutant CALR protein. So verdict is still out. I remain very optimistic that those will move the field forward for our CALR mutated patients, but to what extent, we don't know yet. Still under very early clinical investigation.
Okay. What's the difference between the Incyte approach versus Janssen?
So the Incyte approach is a antibody. It's just a protein that it's very simple, that just tags the mutant CALR protein that's expressed on the surface of the myelofibrosis cells or ET cells if you have essential thrombocythemia, and internalizes those proteins and causes those cells to die. So it's a very simple approach to it. The Janssen approach with the BiTE is more complex, but also very fascinating. It is taking a molecule that can recognize the mutant CALR expressing cells and engage what are called T cells, which are lymphocytes, immune cells, introduce them and try to cause an immune response to the abnormal myelofibrosis cells. So it is, both approaches are trying to exploit the fact that the mutant CALR protein is expressed on the surface of cells, but they're doing it in slightly different ways.
Okay, thank you. Just coming back to Besremi for a second, is that providing any improvement in anemia?
You know, I would say that's hard to say right now. We have some data that mostly comes out of Asia with Besremi in patients with myelofibrosis. It has been studied mostly in patients with polycythemia vera now increasingly in essential thrombocythemia. But there is data for particularly early on in myelofibrosis where you can stabilize aspects of the disease, reduce mutation levels, and likely change the way the disease behaves and potentially the progression of disease. But the amount or the effect of Besremi on anemia, I don't think is well characterized at this point.
Okay, great, thank you. And then somebody just asked the billion-dollar question. What are the odds of a disease-modifying drug?
So yeah, that's definitely the billion-dollar question. It's the question that we ask ourselves at every meeting. I just got back from one of the meetings in Houston last night, and that was part of the discussion at the meeting, which is, first of all, what is disease modifying? Like, what does it actually mean? What's the definition of it? Because, you know, we have drugs that modify the spleen, the hemoglobin levels for patients who have anemia, the symptoms, and even to some extent, all of these drugs reduce fibrosis in a proportion of patients. But what I think disease modifying really means to a patient is to modify the course of the disease, the outcome of the disease. So I think to refine that, I would say, you know, when are we going to get a disease course modifying drug? And that's one of the important parts of why we have to follow up these studies like the Manifest-2 study. We need to follow the patients over time to see, are they doing better over time if they get a drug like pelabresib? Are they living longer? Are they living longer and better? Are they less likely to have progressive disease, less likely to die from their disease? That would be most meaningful, I think, to patients, a disease course modifying drug. That is what drives me to work I walk to work every day, is trying to understand how do we develop these drugs and how do we responsibly test these drugs in appropriate patients so we can figure out where we're going to move to a disease modifying and course modifying drug. The mutant CALR antibody approach, that might be disease course modifying. There are new JAK inhibitors that might be even more potent than the ones that we have from companies like Ajax or Incyte. They could be disease course modifying. We don't know yet. We have drugs that I didn't even get to, like this drug selinexor that has shown some really deep responses early on, or a drug called navtemadlin. Those could be disease modifying. We have some signals already that they may have some disease modification. But it's really important in these trials that we follow patients over time to see, do they actually modify the course? Do they actually remit the disease in a meaningful way that then allows patients to live with a good quality of life? And that's,
Well,
you know, that's still being evaluated.
well, that's an absolutely wonderful answer. We're almost at time. Last question I do have is there anything that patients can do to try to improve their outcomes in terms of lifestyle factors or things that they should be doing that you would suggest?
So that's a really important question. And I think there are a number of things patients can do. And I see patients doing this all the time. You know, one of them is you know, living the best life possible in terms of diet. I mean, I think the worst things patients can do, and it's the obvious things, is eat the stuff that I like to eat, like the fried foods and, you know, the unhealthy foods. I think a Mediterranean diet, patients who move, who stay active if they can, will tend to do better than patients who don't. Patients who don't smoke will do better than patients who smoke. So there are certain obvious modifiable cardiovascular risk factors and just lifestyle choices that make sense. There's no clear ingredient or supplement that I could say that I really believe, you know, is modifying of someone's course and their disease. I think patients who are engaged with their healthcare and participate and are present and are, you know, following along do better than patients who sort of check out and and don't follow up or aren't compliant with their medications. And then, of course, I'll give you my self-promoting one. See a specialist. I mean, if you're not seeing someone who does this exclusively, you may be missing out on opportunities for approved drugs that might make sense, or even clinical trial options. And I firmly believe that patients who participate in clinical trials generally do better, because there's a lot more oversight and a lot more opportunity to build on standard of care.
Oh, that's great. Thank you. I know we've reached the end of our hour, which went really quick. I'm going to turn it over to Kim for a minute.
Okay, thank you. Thanks so much, Dr. Mascarenhas. What a wonderful, wonderful presentation. Very appreciative. Hopefully everyone had a chance to ask their questions. I know there are still some outstanding. I'm going to put an email address in the chat section so you can still send your questions. The ones that are already in the chat section, I'll have. And we can summarize those and send those to Dr. Mascarenhas at another time. I especially want to thank the MPN Education Foundation for helping to put together today's webinar. Hopefully it was provided much needed information to all of you. Just also a reminder that I'm going to put a link to a program webinar evaluation form. If you could just take a few minutes and complete that, it would be much appreciated. Again, that helps us to determine content for future webinars. Turn it back over to MPN Education Foundation. I don't know if anyone else had any additional comments.
Joanne or David?
I just want to thank Dr. Mascarenhas. In my experience, all talks are praised as excellent talks. I think this was an elegant talk geared to the patients who are the target of your efforts. Thank you so much. That was wonderful.
Thanks, David. I appreciate that. And I'll just again, I'm more than happy to try to answer questions that that I can't answer. I'm always careful not to try to play a virtual physician to a patient I've never met. But I did put my email in the chat box. So if patients want to reach out and hopefully not ask me a really impossible question, I'm happy to respond.
Right. And I looked at the chat as it came through quickly, and I think I noticed that you have a comma where there should be a period. And if I'm mistaken, I apologize, but I don't want anybody to get frustrated.
Sorry, I don't have my glasses on. That's a good call. Yeah, it would be .edu, not comma edu.
Right.
Right. And the webinar questionnaire is with SurveyMonkey, and Kim has put that link in the chat as well. If everyone could fill that, I thought that would be great. Again, thank you very much, Dr. Mascarenhas, and Kim, thank you and Plexus Communications for helping us with the seminar.
Thank you.
Have a great day, everyone.
Thank you.
Thanks, Mark.
Good.
I'll leave the link open for a few minutes if anyone needs to get the addresses, the email addresses, or the web link. We also will be sending you a link to the evaluation form.
Thank you, Kim. Really appreciate
Thank you, Joanne.
us together.
Appreciate it. Have a good rest of the weekend. I just reposted Dr. Mascarenhas's email if anyone needs to see that.